We will move to the next topic. The next speaker is Liu Huang Bang. This topic is the PCI horizon scan, incremental value of imaging vulnerability.
You have the slides, please? Oh, okay. Okay. Good morning, everyone. Thank you very much for the invitation. I'll talk about PCI, horizon scan, incremental value of imaging vulnerability. So, who's vulnerable? We know that 4 to 7 million lives are lost due to sudden cardiac death yearly worldwide. And as we speak, every minute, 8 to 13 people died, and many of these are heart attacks. Who's vulnerable? And we have some insights, none other than from our famous pathologist, Dr. Vermani and his team. Lessons from sudden cardiac death, a review of the morphological changes noted in the atherosclerotic lesions among patients who have died. And this is the current paradigm that we understand, that majority of these are due to ruptured fibrous cap of the atheroma, exposing the porridge-like material, which is very thrombogenic, and that leads to a cascade of platelet aggregation and clotting, and that occlusion of the lumen. But we also know this is only in 60% of the lesions that are in these patients. The remaining 40% actually have erosion, whereby there is actually no evidence of a plaque rupture or fissure. And this is what erosion means. When we look at the imaging, we actually see thrombus forming adjacent to a plaque, but there's no evidence of a plaque rupture. So this is from there, they look at what are the causes. So when we see thrombus, it's not just rupture, but it can be erosion and even calcific nodules. You look at there, majority of cause are due to rupture, but there are some differences among the ages and also the gender. For us who work in the cath lab, not in the morgue, yeah? The plaque composition for us, we need to know with our patient. We need to visualize high-risk plaque. If we can predict, we can prevent. And of course, for us, you can help us to make better decisions in the cath lab. For IVUS, the vulnerable plaque, this is a very classic appearance. We see an eccentric plaque. The plaque burden can be more than 70%. And often we see microcalcification. We see outward remodeling of the vessel with attenuated echolucency. And often adjacent to this, we also see the plaque which is more echogenic and fibrofatty in nature. But these are gray scales and they are not easy. And PROSPECT study was first of a study that looked at IVUS and whether we follow up these plaques and see whether there are events. There are 697 patients that underwent grayscale IVUS. We pull back on all the vessels and then we follow up these patients over 2 years. No intervention, just observation. What have we learned? We learned that over that period of follow-up, 11.6% of non-culprit events were noted. And what are the lesions that we're looking at? The predictors, of course, at the patient level are the high-risk patients like diabetic. Having a history of PCI means that they have more risk. Patients with plaque burden of more than 70% and the thin cap fibroatheroma, or TICFA, and the mimolumen area, or less than 4 millimeters square, are the high-risk lesions. But this is just the tip of the iceberg. We know that majority of our MI patients do not have a high-risk, high stenosis plaque. Majority are in fact less than 50%. Even some studies show 97% of the MI have a plaque of less than 70%. So when we see things like this, a grayscale IVUS is blurry. We don't see very clearly. We don't know what we are sure, what we are not sure. Of course, if we have better resolution, we see better, but it is still black and white. What if we have color? Wouldn't it be much better? And if the color can tell us about vulnerability, would it be much better? So here you are, we have a technology now that potentially can give us insight about vulnerability. So IVUS with near-infrared spectroscopy, a technology that has been launched not that long ago, less than 10 years ago in Japan, and has been used to assess the particular phenotype of plaque, the lipid-rich plaque, LRP. Now, this technology is not that easy to understand, but I try to keep it simple. It gives us a display of a chemogram. So imagine the scan, a pullback on the vessel, and you have a circumference of the vessel, and then you open it up like a piece of paper, and you lay it flat, and you get a map of this vessel wall. And if we have a healthy vessel, it's all red. But when we have large lipid plaque, it will show up as yellow. So I think this is a very good information because it tells us where the location of the plaque. It tells us about the arc of the plaque, whether it is circumferential, 90 degree, 180 degree. So it also tells us about the density of the plaque. And this is a concept which is something which is new for us to grasp. And I like to think of it like this. This is my hometown in KK, and I can see here the backdrop, Mount Kinabalu. And I also see a lot of ranges, a lot of hills, a lot of mountains. And I like to see this as just like how I look at chemogram. I have where the plaques are quite mature, or even some segments which is very low-lying and very normal. But at the same time, I know there are levels where the plaque has become very dense or very vulnerable. So this is probably the way we have to image when we do an imaging in the coronary, as we go down the lumen to look at what happens in the vessel wall. There are robust clinical evidence for this technology. It is the first ever FDA cleared imaging device to look at high-risk plaque. And it has predicted 89% of high-risk patients where there's a presence of large lipid plaque. I will show you the study. There's a 37-fold increased risk of MACE when we can detect a large amount of lipid in the plaque. And this is what we want to know. When we do an angiography, when we have a near normal coronary, a patient who came to us with some chest pain, now how do we know whether this is actually a high-risk lesion or whether this patient has microvascular disease? This patient, for instance, came back 7 months later and showed that there is a progression of a stenosis. When we go back and look at this, the LRP, it was obvious. There was this yellow blotch on the chemogram. So it was able to predict. And this is one of the studies that look at it, the LRP study, that evaluated the correlations of the presence of non-intervened, or just observational, or non-flow limiting lipid-rich plaque and how MACE developed over 2 years. And what we learn here is when the plaque is very, very high in burden, and there's an index which is called the Lipid Core Burden Index, or LCBI, and it gives us automated where it is the highest when we have a pullback in that adjacent 4 millimeter. So it's called LCBI 4 millimeter. When we have a value of more than 400, that segment is correlated to an 89% higher risk or 4-fold risk of a MACE event. And here's an example. A lesion which is not that dissimilar from what we have seen from Dr. Lam. A moderate lesion. Now, how do we know in the next 22 months whether this patient will have high risk? So in this case, the LCBI was 400 or more. So we know that patient, in this case, there was an event further down the line. And this is what we have seen. When we compare those plaques, as we said, they are not more than 70%. They are less than 70%. But when they have an LCBI of more than 324 or less than 324, that itself predict a 6.5-fold higher risk of MACE in this lipid-rich plaque. Now, when we look at those plaques that are more than 70% in the red, what do we see? They are much higher, of course, compared to the blues. Yeah? But when we have additional information, not just that lumen, but we also have the LCBI max, what we see here. The highest risk among the patients are the one with the lumen, which is 70%, plaque burden, which is 70%, and the LCBI of more than 324. That group, if you compare to those patients who have no high lipid core burden index, is 3-fold higher. When we compare to those patients that have a low-grade plaque and low lipid, it's a 35-fold, 37-fold. Okay? So this is an example of a patient who has this. There's a lesion where you have non-culprit lesion 1 and 2, but you can see the LCBI are different. So the segment where the LCBI is high later turn out to have a event. So we have observational evidence, but the next question is, can we do something about it? And this is where we talk about preventive PCI, that we can intervene. Maybe we can change the outcome. And there's a study, or the PREVENT study, that look at this. Patients who have non-physiologic plaque, but high risk, high lipid profile. Then the PREVENT study randomizes patient to PCI or optimal macrotherapy. And this is the outcome at 2 years. You can see across the board, less death, less MI, less ischemic-driven TVR. And when we follow this patient for the next 7 years, we continue to see the difference. And this is one of the study that look at the plaque criteria based on IVUS, OCT, and NIR. So 4 criteria, as we heard, MLA or less than 4 millimeters square, plaque burden of more than 70%. But on top of that, we look at whether there's evidence of TICFA, as in thin cap fibroatheroma, from OCT, a cap of less than 65 microns, or when we have NIR, or more than 315. So we have this technology now in Malaysia, and we have used some of them. And I just show you one case. This is a patient with anterior MI, he's got LAD, and you can see that lesion here, which is moderate to severe. I would say that eyeballing, IVUS, you would say this is a FFR. Yeah, Dr. Lamho, this would be more or less than 0.8. I would say less than 0.8. With a history of MI, of course, we know we need to treat this. This is vulnerable. So this is angio-based decision making. We look at the shoulder, and then we look at grayscale IVUS, but on top of that, we also have the lipid. So we know where the lipid are, where the high-risk lesions are, and we want to know the landing, got to cover this lesion. And in this case, that's what we did. We treated the lesion, prepared it, and then we treated with a DCB. So after DCB, the LCBI come down. So the signal is not because of the stent blocking it. So it does come down. And this is what we have. Before, the LCBI was 626. After, it is 192. This is not just an isolated case. We also have a study that look at this. So this is the DEBUT, or DEBUT, debut ARP study, that look at drug-coated balloon, sequence please, in vulnerable lipid-rich plaque. And they have looked at patients, similar like I was showing you, that they have initially high LCBI, or 397, and post-treatment at 9 months, it came down to 210. And it showed that it is feasible, and this patient MACE rate is low. What is more exciting now is ongoing. As of last month, this study has started, targeting 400 patients, drug-coated balloon versus guided directed macrotherapy in treatment of lipid-rich plaque. So we're really exciting to hear more about this technology. Now, zoom out a little bit from invasive. We also know it would be even more exciting if we can have technology which is non-invasive, for instance, CT scans, to look at whether we can detect vulnerable plaque. And it is coming. If we can find vulnerable plaque, that means we can have new treatment, even new generation of bioadaptive stents, drug-coated balloon, bioabsorbable scaffolding, that we don't have to cage this vessel. So the combination of this technology, the imaging, the intervention, hopefully will change the natural history of our patient. And these technologies are coming, AI-based CT. And if you look at the literature in the last month, very exciting. FDA has cleared another new AI-enabled coronary plaque analysis software in CT. And there are more to come, getting more and more exciting. Okay? So for now, what we have is, those of us who work in the lab, we have IVUS, and we have this NIR, and this technology is combined. So this is where the Makoto comes in. So it's actually 2 in 1. So for IVUS, we look at the stenosis, we can size the vessel, we can look at the length, we can look at the plaque burden, we can look at the plaque characteristic. It guides our decision how to prepare, optimize our DCB or DES PCI treatment. NIR give us more. They give us quantitation of the lipid. It is vulnerable assessment. It improved the precision of our procedure. So I would declare my conflict of interest, of course. I am here because of the sponsorship, the goodwill of NIPRO, but otherwise the science is science. I do think this technology holds a lot of promise. Thank you very much.
Thanks very much, Dr. Liu. We are actually just a little bit of time because we started late. Maybe I'd just like to invite our panelists, if there are any questions that we can direct to the various speakers. Ramesh, perhaps you'd like to start.
Actually, Lam Ho, your first case, while it appeared disease, I think you noticed there was a slow flow before you even decided to intervene, right? Yes. And then you had no, or at least even slower flow after that. Correct? After you stented.
After stenting.
Yeah, but before also the flow was slow.
Yeah. Before
right?
The flow is slow. After stenting, probably because of lipid-rich part. After stenting, high pressure, there's slightly slow flow, no refill, and then we give adenosine. But the final angiogram, the flow is okay. But if there's no comparison, you just see the P-angio. It's controversial whether you need to stent or not, or it's difficult to decide whether to stent or not just based on angiogram to see the flow, because sometimes it's not reliable.
But when you see that initial slow flow, I'm not sure whether the mu FR would actually be accurate, you know.
I am not an expert on that. Just a clinician. I try to apply this technology in my daily practice. I find it's useful for this degree of slightly slow flow something. Usually it will work.
I see.
Thanks. And we had used it to detect many minor difference in something you can just detect by OCT, but the mu file can help you to find out the difference.
Thank you very much. Any questions, Dr. Hong or Dr. Dat? Dr. Dat, yes.
I have a question for Professor Ho Tung Sung and Prof. Yogi K also. We all know that Minoca and Nuca is quite a difficult issue in our community already. It serves as an endpoint diagnostic for the microvascular dysfunction. Possibly that we can use a lot of tests to check what phenotype of the Minoca and Inoca also. But in some very remote area in Vietnam, we don't have enough tests to have to final diagnose of the Minoca Inoca. So we are writing the consensus and the recommendation for the chronic coronary artery. Do you agree that if the patient suffer from the typical chest pain, no obstructive of the epicardial coronary, and we excluded all the cause of the angina, we can directly to treat the patient as the Minoca, Inoca, or Anoca in that situation?
Okay, thank you for question. The Inoca and Anoca is the first criteria in a non-obstructive coronary artery disease in the coronary angiogram. And if the patient have the angina, on the angina, if we don't do any test about non-invasive functional testing, look like SPECT or BET or CMR, we talk about Inoca. If we have the positive non-invasive invasive test before, we have the Inoca ischemic. So if we don't do anything, we do the exclusion. It means non-obstructive of the coronary artery disease, and we do FFR greater than 0.8. We can suspect because we don't do non-invasive functioning testing according to the guideline. So you can suspect and you can give the treatment look like the guidelines recommend calcium channel, nitrate, or so on. Yeah, I think so.
I think the area here continues to be, how do I put it, continues to have lots of opportunities for research, because some of these investigations with the physiologic testing are not straightforward with continuous thermal dilution, for example. So I think a lot more needs to be done before it becomes mainstream practice. Perhaps the last question, Dr. Hong, do you have any questions for Dr. Hong? For any one of the speakers?
Yeah, I have a question for Dr. Lamho. Yeah, as your lecture, so I have a MUFR no need to spread why. So I want to know the zeros. Is zero of MUFR the same FFR or not? Isn't it different?
For MUFR, no need wire.
Yes.
Just
Right,
enter.
right. No need why. I know. I want to know. I want to know the results. The same.
Yeah,
Yes, the same FFR.
most of the time it correlate.
Yeah.
Yeah. So far, because you need to pay MUFR and you need to pay FFR, it's not very reasonable to do double payment. So we just check for few case and they all correlate. The exact correlation that you can check with the paper, they said it's more than 95%. Nowadays, they have they think the degree of reliability, the first one is invasive FFR, second is MUFR, the third is IFR. Of course, all this is controversial, still controversial, but what we know, what we are sure is in ESC guideline is class 1B. Yeah, that's enough because for any medical legal issue, just show the ESC guideline.
Yeah. So maybe it's timely then that we bring this to a close. I just have one little comment for Dr. Liu's very nice talk. And I think, I was asking myself, my goodness, this thing looks better than sliced bread. When am I not using it? But of course, we know that there are implications. The technology, a 37-fold improvement in outcomes has to be understood in the context of a 0.2% event rate in the base group, which of course means that your number needed to treat is very high. And then, of course, there's competing data from BCIS ischemia trial and a whole bunch of other studies that suggest that it's not so straightforward. So I think with that kind of introduction and from all the talks by all our distinguished speakers, and I think it's timely to close the session. We're just slightly beyond time, but I'd like to thank my co-chair and all our speakers and panelists for their roles. Thank you very much.